Good afternoon, everyone. Thank you for the introduction. So my name is Jackie and I'm a radiation therapist at the Olivia Newton-John Cancer Wellness and Research Centre. So today I'm actually really excited to share with you all our department's experience transitioning to surface-guided radiation therapy using SimRT. So, as you've heard, surface guidance radiation therapy is becoming increasingly recognised for its benefits. But transitioning from an established system like the active breathing coordinator requires careful planning and adaptation. So in this presentation, I really want to take you through how we switch from ABC to SGRT for our deep inspiration breath hold breast cancer patients. I'll also highlight the role that SimRT had in supporting its integration into clinical practice, as well as the impact it had on our workflow, patient, and therapist experiences. So to begin, at ONJ, ABC was the mainstay for our DIBH treatments. And for those of you who may be unfamiliar with it, ABC is our breath hold control system, which requires a dedicated trolley setup. So it consists of a mouthpiece, which we often compare to a snorkel, a nose peg, and tubing connected to a spirometer to accurately measure the patient's lung volume. So that's what you can see in that image up above of the patient setup. So the smaller image displays the patient's breathing trace, and this is what we monitor throughout simulation and treatment. So the system works by having the patient breathe up to a predefined lung volume. And it's at this point where the ABC system will effectively lock their breath into the same place. And this ensures consistency of our breath holds. So now, while ABC has allowed us to achieve an achievable and reproducible breath hold, it did come with some challenges. Many of our patients found that the mouthpiece and nose peg could be quite restrictive and uncomfortable for our patients, and this often led to feelings of anxiety. For this reason, patient compliance during simulation and treatment could also be difficult. Daily quality assurance and additional setup time of the system impacted our workflows, and it really prolonged our simulation appointment times. However, despite these barriers, over the last 10 years, we have had good success in achieving DIBH for our breast cancer patients. So then the question you might be asking is, why did we make the shift to SGRT? So the biggest barrier we faced with our current workflow was the requirement for tattoos during patient positioning. Although ABC has served us well for over a decade, the growing demand for tattoo-free treatments was a key driver for change, and it really prompted us to look at alternative solutions like SGRT. So therefore, what SGRT offered us was a contactless, non-invasive, and tattoo-less approach. We sought to improve our patient experiences with increased comfort and hopefully efficiency in our workflows as well. But before we could fully transition to SGRT, we actually needed a way to validate that the patients could achieve and maintain a stable breath hold. And this is where the SimRT system became instrumental. So what is SimRT? SimRT is a simulation-based tool designed to track patient motion in real time during CT. To give you a bit of a quick rundown of what the system is and what it entails, I have a video here from our vendor. So hopefully that will work.
SimRT is our solution for non-invasive motion monitoring. For 4D and breath hold CT, it affords non-contact surface-guided CT, a simple workflow with no hardware setups and no surrogates. Designed for both 4D CT and breath hold CT, SimRT makes breath hold assessment and training easy for efficient, successful treatments. With the patient side option, therapists can stay close to the patient for longer and easily coach practice breath holds. SimRT has a proven record of reducing rescan rates.
So at ONJ, we were very fortunate that this system wasn't unfamiliar to us, as we currently use it for our lung and abdominal 4D CT scans. This prior experience really helped aid in a more efficient implementation process. So what did that look like? So the transition from ABC to SGRT wasn't just about switching the technology. It really required a structured approach to ensure its smooth integration into clinical practice. So here on this slide, I've got our implementation roadmap. And this is what we followed for implementing the technology into our department. And I've broken it down into 4 main phases. So with our first phase, it involved building the foundation. So we began with super user training, where a select group of radiation therapists would become experts in SimRT and lead the implementation process. So these super users underwent comprehensive hands-on training to understand the system's capabilities and limitations. It was from here that we were able to draft new protocols, and it really required a shift in how we approach DIBH and our patient positioning. So our team worked collaboratively with other SGRT users who currently work with or who have had previous experience with the system. And fortunately for us, we did have some of our colleagues who had previous experience with the system in their previous departments. And this really helped develop protocols that prioritised our patient comfort, therapist efficiency, and clinical accuracy. We also consulted our physics team to ensure that we anticipated any potential challenges before we could move forward. So with the foundation set, the next step was our system installation. As we already have the system in place at ONJ, this stage really just involving upgrading our SGRT camera to the new update, which was our Horizon cameras, and then commissioning for these. So during this phase, our physics team worked diligently to perform extensive acceptance testing and quality assurance tests to ensure that there was optimal accuracy and validate its real-time tracking abilities. And this was all essential before we moved on to our patient training, team training, sorry. So our third phase was really just perfecting the process. Over the course of a day, we worked with our vendor to conduct a hands-on training session and ensured that the simulation staff and super users understood the nuances of SGRT. Also, to really help refine our workflows, we conducted mock DIBH sessions using our staff volunteers, and these sessions really helped us identify any potential workflow bottlenecks. It also helped with ensuring consistency in our therapist techniques, as well as fine-tune our patient coaching strategies. One of the most valuable insights that we actually gained from this phase was the importance of clear real-time communication between our radiation therapist inside our CT room, as well as our radiation therapist in our console room. I'll kind of touch on the process that we use at our centre in a little bit, but this feedback loop was essential in ensuring that we had a breath hold that was reproducible. Overall, this whole entire third phase was an iterative process, and once we had finalised our protocols, we were ready to move into clinical implementation. So putting our refined workflows into action was our final step. We identified an initial cohort of 5 breast cancer patients to undergo our SGRT-based CT simulation. During these initial patient simulations, we closely monitored our patients for comfort and compliance, as well as refined our real-time breath holding techniques. Overall, the entire implementation process was a structured approach, and it allowed us to transition confidently and effectively, ensuring that both our therapists as well as our patients felt supported throughout the entire process. The gradual implementation with our initial cohort also allowed our therapists to build confidence in a controlled manner. So how exactly do we use SimRT in our centre? So our process for SimRT involves several key steps. Firstly, our patient is positioned outside the bore, where we use external lasers to coach them into a breath hold. Using these lasers, we mark 3 markers, which are placed on the skin to indicate free breathing, a maximum deep breath level, and a comfortable deep breath in level. Once our therapist is confident that the patient can meet our breath hold criteria, we move them into the bore and align them for tracking with our SimRT software. So one RT will stay inside the room with our patient, while the other will monitor their breathing trace at the console using SimRT. We guide our patient back into breath hold, and the therapist will check the alignment of the breath hold in the CT room with internal lasers. If stable, our radiation therapist inside the CT room will give a thumbs up or some kind of indication to to the therapist in the console room, saying that we're happy to set our breath hold range and verify its reproducibility. Once that consistency is confirmed, the scan is then performed, obviously after our radiation therapist leaves the CT room. So the fact that the SimRT software gave us the ability to confirm reproducibility before scanning was what excited us most about the software. But this was not the only impact that the software had. So the transition to SGRT had impactful benefits, from streamlining our workflows to improving patient comfort. I now want to take a look at the 3 main specific perspectives: clinical, therapist, and patient, to really highlight these key outcomes. So from a clinical perspective, SGRT simplified our workflows. Without the need to set up our ABC trolley, CT simulation processes became much more efficient. And we were able to successfully decrease our appointment times down to 45 minutes, compared to the 1 hour and 15 minutes we had previously allocated to our ABC DIBH patients. This slide really highlights the differences between our previous workflow and our current SGRT workflow. Without the need to set up the equipment and explain the ABC system to our patients, we were able to eliminate the amount of time that our therapists spent on managing equipment and could spend more time on focusing on providing direct patient care. In addition, without the presence of the snorkel, constant feedback between the RTs and patients was possible, and this allowed for a more simplified coaching approach. Taking a look at our therapist perspective, feedback from our therapist said that it was less labour intensive. The streamlined approach allowed them to devote more attention to patient education, coaching, and positioning. However, a key challenge that our therapists faced or encountered was the loss of a precise volumetric control over patient breathing. So with ABC, our therapists had access to a quantifiable lung volume, ensuring that each breath hold was consistent. In contrast, SimRT really only provided us a visual qualitative assessment rather than that numerical lung volume readout. So to overcome this challenge and kind of help build our therapists' confidence in the system, protocols were developed to define clear breath hold criteria. So for example, no arching or tensing, no leaking, and can hold their breath for around 20 to 25 seconds. And this was to ensure consistency without those direct volume measurements. We also included constant reproducibility checks using our SimRT software throughout the workflow, which allowed our therapists to assess and verify patient stability before CT scanning. The mock simulations and training sessions that we held helped our therapists develop their confidence in recognising that stable breath hold using the SimRT software. Ultimately, while that transition from a quantitative to a qualitative assessment method required adaptation, SimRT's real-time visualization tools and the structured coaching techniques that we developed helped our therapists build confidence and build the assurance that they needed to ensure accurate and reproducible DIBH treatments. For patients, the transition to SGRT was transformational. It improved both comfort and confidence throughout their treatment. So here are a few quotes from our patients who experienced SGRT. So I had picked up a brochure on my first visit and it mentioned tattoos. Whilst it didn't upset me, the big thing about it was that it would be a reminder. So it was a nice surprise learning that I wouldn't need tattoos. From one of our patients on treatment who transitioned from ABC to SGRT, mentioned that without the snorkel, I felt more relaxed and the breath hold was easier to maintain. So the non-invasive, tattoo-less approach not only reduced physical discomfort, but it also played a crucial role in improving and lowering patient anxiety and allowed for better engagement during DIBH coaching. The elimination of the restrictive mouthpiece and nose peg meant that patients experienced greater ease and control over their breath hold, ultimately leading to improved compliance and a more positive treatment outcome. This highlights the importance of patient-centered care, where these small changes in technology and technique can really make a huge difference in the physical comfort and emotional well-being of our patients. So taking a look at those key insights and next steps for us. Our transition to SGRT taught us some valuable lessons. It enhanced clinical efficiency and streamlined our workflows. It improved patient satisfaction due to increased comfort. ONJ's structured and gradual implementation process provides valuable insights into the value of non-invasive surface tracking. These lessons really highlight the importance of embracing these new technologies that prioritize our patient and therapist needs. Moving forward, there is great potential to continue to refine our SGRT and DIBH workflows. We are only 3 months in and we are continuing to learn how to use the software. And we would particularly like to look further at these refinements as we expand our technology to a larger cohort of breast DIBH patients. We are also exploring the use of the SimRT software for other treatment sites, including SGRT-guided lung and abdominal treatments and stereotactic body radiation therapy. We'll continue to refine our workflows with research opportunities playing a key role in driving these advancements and ensure that SGRT aligns with best clinical practices. So in summary, SimRT played a crucial role in the transition to SGRT. It allowed us to validate our breath hold reproducibility and integrate the SGRT system with confidence. The transition demonstrates the power of innovation in radiation therapy, improving efficiency, patient comfort, and our therapist experiences. For departments considering a similar shift, our experience at ONJ highlights key takeaways that can help guide a smooth and successful implementation.